So the topic of today, my presentation is study designs. What are the different type of study designs? What are the bias when we are selecting any design before conducting the experiment or the research? How do we randomize the sample? Randomization, different types of randomizations are there. We cannot, just blindly take a sample and we can conduct a research study. And how are they actually applicable for the biostatistical application? I am Brother Seni, and I work for the WHO in the Department of Community Mental Health Service. So the contents for what we are going to study today are types of study design, the strengths and weaknesses of each type of study design, appropriate uses of different study designs, type of study design needed to answer a research question, and what is the need for repeatability, means the reliability and validity of a research design. So the first thing is, what is a health research? First is a lab research. Like the lab research is where we are actually having a laboratory, or what we can say a clinical research. In this kind of research, what we are doing is we are actually developing different kind of new clinical protocols, different kind of new procedures, or we are actually testing a new drug, like any new pharmacological drug in the laboratory. Okay. And where there are different strategies to prevent, control, and understand the mechanisms of health-related phenomena. So basically, the lab research, if we go for the lab research, what we will find here is that, like right now, we had the epidemic of corona. Okay, we had the corona epidemic in this is the kind of, you can say, a kind of pandemic which has engulfed the entire world. So a new kind of drug was being invented by the government of India. So that will be undergoing a lab research. Okay. Secondly, we have the epidemic investigations anywhere around the world. Like we had Zika virus, we had now the latest coronavirus, we had the in the country Sierra Leone, where I was posted earlier. We had kind of what we call as Ebola hemorrhagic fever, Ebola virus disease. Okay, it's another viral disease, EVD, we call it Ebola viral disease. In this, we have large epidemic outbreaks. In this case, the epidemiologists of that area, along with the Ministry of Health of that area, they are collaborating with the WHO, World Health Organization. Like in India, we are under the CRO, that is the Southeast Asian Regional Organization. Africa has its own, you can say, organization having the headquarters somewhere in Ethiopia. Okay, so they will be conducting what is the reason for that outbreak, what kind of transmission, how the transmission, what is the route of transmission, what is the agent, host, and environment, and what is their interaction, what led to the disease spread, how this disease took the form of an epidemic and even further pandemic, like we had the pandemic of corona. Okay, and what can be the control measures, that is the prevention and control measures, and further comes the rehabilitation, which we will be doing with collaboration with the governments of those countries wherever the disease is spread. Then we have is the population based research or the field study. In this kind of study, we have like it is going on continuous basis, or you can say a basis where there is, I mean, like we are studying, like right now, in India, we have this month of July is going on. Sorry, July is coming up. Right now we have June. There are a lot of cases of gastroenteritis in the community. We have a lot of cases of typhoid, we have cholera, we have diarrhea, dysentery. Okay, in this kind of season, in the kind of monsoon season, you can say we have this kind of disease. So they are kind of ongoing kind of, you can say, researches, which are called as the population-based or the field researches, in which we are actually studying the distribution of the disease, how the disease is spread. Is it sporadic in nature? Is it endemic in nature? Or is it epidemic in nature? And then what are the determinants of the disease? What are the different kind of risk factors for that disease? Is it because of the monsoons? Is it because of the contaminated water? Is it because of some environmental factor? What are the different kind of environmental factors? Okay, control measures of the health related phenomena in chosen populations. What are the control measures which already people are undertaking? What are the governmental measures? How are we evaluating them? Okay, even if the government is giving them the clean water, then why we have so many children, so many mothers, and so many infants dying because of the diarrheal disease? Then we have, this is followed by some suitable biostatistical techniques. Either we go for some statistical tests. We have the T test, we have the T pair test, we have the Z test, we have ANOVA, we have ANCOVA. They are the further biostatistical technique, which will be further coming up depending again upon the randomization or the what kind of sample size you are taking and what kind of the research you are undertaking, whether it's descriptive, whether it is observational, or whether it is experimental. So now, if we go further, now there are two basic methods of data collection. One is the primary and second is the secondary method. In the primary method, what I am taking, if I am the principal investigator and I have a full team of investigators with me, I will be collecting the data first. This will be through medical examinations, lab tests, focus group interviews, or we can have direct interviews. We have focus group interviews. We have, you can say, there are semi-structured interviews. We have dichotomous questions like yes or no, or we can have telephonic interviews. There are different kind of interviews. Then we see a lot of things by observations. Okay. Here the merits are there are less measurement errors because I am myself and my team is trained enough to take the data. Up now in those cases, and we are actually suiting with the objectives of the study. Please make sure there is a lot of difference between assumption and hypothesis. What is hypothesis? It's basically the relationship between the two variables. What is basically assumption? We are just assuming something, speculating something based upon our knowledge or previous experiences. So never make any kind of decision based on your assumptions. Either it has to be a hypothesis and that has to be tested by an experiment or by a research study. Further types of studies I will be discussing right now. We have the secondary method of data collection in which the data is collected by another party, by another third person, or you can say, or by a third party or by somebody else whom you are either employing to take the data, or and the sources or some medical records are there. For example, you want to study the different factors which led to corona in the year 2020 when WHO declared corona to be a pandemic. Okay, you want to study in some part of Punjab, like I'm from Patiala. What led to the corona bombardment in the hospital, Government Medical College of Patiala? Okay, you will be seeing all the records and reports. And my dear friends, records and reports are the legal documents, so never tamper with them. So when you are checking the records, anecdotal records, you are even interviewing some people of those times. Okay, there are some group records like we have census data, we have vital statistics, IMR, infant mortality rate, we have MMR, we have fertility rates, different data we have crude death rates, we have disease rates, and so you will be seeing all the records of the hospital. Okay. And those records are obviously collected by the doctors or by the nurses of that hospital, which are further sent to the director of the health services in Chandigarh, is the capital of Punjab. Okay. Further, it goes to director health services in Delhi, and further it goes to WHO. Okay, that's another. I'm just telling something extra from my presentation. So there are two basic sources of data collection. One is the primary, when I myself and my team is collecting the data. But when I am taking data collected by somebody else, either in the present times or in the past times, and I'm relying on, and secondly, I'm relying on the previous records, on the previous interviews, if anyone has recorded. Okay, that will be the secondary data. Then now we have a different kind of study designs. Different kind of study design, like whenever we are basically, when we are, you can say, collecting any kind of, you can say, data we have of any kind of research is planned, the first thing is to define what is a study design. What kind of study are you undertaking? Is it an observational? Is it an experimental? Is it a case control? I mean, I'll be discussing each and every design in quite detail. So study design is a specific plan or protocol for conducting the study. Like when we go for stitching our own wardrobe, we go to our seamstress or we go to our tailors, that this kind of design I want. We cannot just wrap a bed sheet or wrap a full cloth on our bodies and we can go out. No, we have to first of all find out the study design, and that is again based on your ideas of research which are coming up in the mind. What kind of research you are undertaking based on the objectives of that research, specific objectives and general objectives. You will be defining your study design, finding the design and then defining the design as per the objectives. So this allows the investigator to translate the conceptual hypothesis into an operational one. Conceptual hypothesis, concept of the hypothesis. Conceptual means you are conceptualizing the hypothesis. Again, it's the relationship between the two variables. Now you are giving it in a form of potential energy goes into kinetic energy. I'm standing still here. That's potential energy. I'm walking, kinetic energy. Okay, so conceptual hypothesis based on the concepts, whatever hypothesis I have in my mind, I want to test this on this population. I want to see the behavior of the population. I just want to check the knowledge of some people. Okay, what kind of people are they? Which place are they staying? Okay, now this has to be made into an operational one. So a complete, you can say, synopsis has to be made of the research study. So here, this is the study design definition. The choice of particular study design is a fundamental decision in designing a research study to answer a specific research question. To answer a specific research question, we have to have a study design. And that design has to be one, focused by your principal investigator, critically thought. It has to be relevant. Last but not the least, feasible. Please make sure it has to be feasible. So now, what is the need for research design? It facilitates the research operations, obviously planning, and then it has to go congruent with the man, money, and material. Man, time, resources. Otherwise, it's going to be time waste, resource waste, money waste. So there is no fun of it. So it's a kind of direction, like in the movies. If you watch any kind of movie, producer has to give the money for the budget. Directions of the movie to the actors will be given by the director. So this is the kind or need for the research design. So now, when we see the need, now there are different types of study questions which lead to different types of study designs. What kind of question you have in your mind for the research? What is your research question? Not hypothesis. What is the research question? You want to test the knowledge of people regarding corona. You want to test the knowledge of some nurses regarding breast cancer. You want to study the knowledge of adolescents regarding contraceptives or regarding sex education. You want to check the knowledge of some medical college professors regarding biostatistical methods. Okay, this is a simple research question, a very layman, a very vague. Okay, now what kind of design will be used there will be depending upon, again, your research question. Again, make sure money, time, and material. Money and time, budget you have the time and the feasibility issues. Man, money, material. Okay, so the first is your descriptive. Descriptive studies are basically the prevalence of condition Z in a specific population. Prevalence, if you want to see the study of prevalence studies, the prevalence of diabetes in slum dwellers, for example, the prevalence of diabetes in slum dwellers, prevalence of diabetes mellitus 1 or diabetes mellitus 2 in HIV positive people. Second is analytical studies, analysis which we are doing in detail, even though our descriptive analytical studies are also there, but there is another category called as analytical study. Here you will be studying the different factors which will lead to that disease. For example, what factors were there which led to the spread of coronavirus, and it took the form of an epidemic and it took the form of a pandemic across different nations and different countries. So what are the factors which are associated with the condition Z? And is this condition a risk factor, etiological risk factor, or the cause? What are the risk factors? If you want to really study the risk factors that will be coming here. So that depends that you are doing the analysis between two different conditions, agent, host, and environment. What are the different agent factors, host factors? And third one is the diagnostics. Basically, diagnostics are the lab investigations. How good is test Q in detecting the condition Z? So which other kind of tests are required? Diagnostic, here comes your randomized controlled trial or different kind of experimental studies. So now, if we see here, the study designs, the study designs will point to the most appropriate. Here in descriptive study design, we have calculate the proportion of the study population with condition Z. Incidence or prevalence. Prevalence comes the old and the new cases. Incidence is the current cases. Prevalence means all the old cases plus the new cases. Analytical is comparing the frequency of condition Z. What is frequency? How many number of times one situation is repeating? Repetition is frequency. How many number of times? You are comparing the frequency of condition Z among the groups of the population. We have the male population, we have the female. So now you're actually comparing the frequency of the conditions of condition Z. It's just a hypothetical thing I'm telling condition Z, comparing the frequency, how many number of times the disease has it has repeated in one population. How many people are actually undergoing its morbidity and how much is the mortality or the death rate. Then comes the diagnostic. Here comes when we are actually calculating the validity in terms of disease specificity and in terms of disease sensitivity. Here comes the reliability of test Q in detecting the condition Z. I will be discussing about diagnostic in the later part. Now, first of all, I'm saying it has to be relevant. See, now smallpox eradicated from the country in the 1960s. Trachoma eradicated from the country in the 1960s. In the year 2000 and I think between 2005 or 7, India was declared free from polio. Okay, so there is no fun of conducting any kind of studies on its seroprevalence or on these kind of diseases. You should conduct research on a burning issue, burning epidemiological area of interest, or current diseases, or where some national or international importance is concerned. Any kind of evaluatory studies you can do. Like, for example, right now, there was a big study conducted by the ICMR on the efficacy of the Janni Suraksha Yojana, JSY, under the National Health Mission, which was earlier called as the National Rural Health Mission. Now it's called as the National Health Mission. So what is the efficacy of JSY in the state of Odisha? Are the women actually benefited by them? Is all the money which is being given by the World Bank to the NRHM, now called as NHM, is it actually being distributed to the beneficiaries? Or is it only a kind of, you can say, an eyewash? So these kind of evaluatory and monetary studies, I mean, you can conduct any kind of evaluatory and monetary study on any of the government's policies or the government schemes which are run in the community health area, whether it is relevant or not. Secondly, novel, it should make some meaningful contribution to the existing knowledge. Inputs, it has to give inputs to your profession. I'm basically into nursing profession, now turned into public health after having done my MPH. So obviously I'll be doing some research which will be giving some insights, inputs, contributions to my own profession through recommendations. The last chapter, what we have in our thesis is recommendations. The last part, after conclusions, comes with recommendations. Is prior to your bibliography or the references. Is it feasible? Is it feasible? Like, I know I'm a single woman. If I want to go for a research study on 1,000 the population, which is having 1,000 number of participants, do you think it's going to be feasible? Do I have that much of resources with me to do that? Who will be assisting me? Do I have the money? Do I have the budget given to me by the government of India? Or am I the part of any project? Do you think it's feasible? So always make yourself comfortable in terms of man, money, material. No need to be over ambitious. Always be focused on what you want to do, and kindly discuss with some seniors or some senior epidemiologists or some senior researchers in that area. It would be prudent. I'm using the word prudent. So instead of doing any kind of wrong research or taking any kind of wrong research idea and wasting your time and money and material, it's better to see the feasibility of your research in terms of all these three things, what I'm telling you. So selecting is relevance, novel, feasible, and simple. Always avoid all unnecessary. Always go from simple to complex. Okay, like we go step by step when in our life also. Never take any decisions which are very, very harsh, which you are not able to do. It's good to be an ambitious person, to take up challenges, but it's foolishness. Take up an idea which is not reliable, which is not meaningful, which is not feasible. So now comes basically who is the patient or what the problem is being addressed. So now this is what is the intervention or the exposure. What is the comparison group which you are comparing, and what is the outcome or the endpoint? Okay, there are two things in the class. I am working in WHO. Might be many of you might also be working in different kind of government of India's projects. I have Dharminder, my best friend, sitting here from NIH. We are both sharing equal positions, but he is PhD biostats. I am not PhD of biostats. I am not masters. So he will have more knowledge of biostats than me. So I compared based on the qualification, experience. You can say a control group is the Dharmender's qualification. So we cannot compare two things just based on our, you can say, subjective knowledge. It has to be objective. So a comparison group has to be there when you are testing the efficacy of two medications, or when you are testing any kind of new intervention in a research study. For example, you want to see that which catheter size is good for urinary catheterization of a male patient. There has to be a control group. Then only you can find the good results. Or you want to see like this BCG injections are given intradermally in a newborn child, as we all know. Lot of clinical trials took place because the child used to weep a lot. Okay, so then ultimately there's a gauze of syringes. We have different gauze of syringes which were, prescribed by WHO or recommended by WHO. This kind of syringes you can use with babies. Pain will be minimized. Similarly, is when you insert an IV cannula, please make sure that the patient has minimum pain. Even you can go ahead for such kind of studies where you can see the pain levels of patients when they're getting IV insulation, insertion administration. So without a control group, you cannot make any kind of decision. So on the basis of classification, we have observational study. On the basis of your observation, experimental studies are also called as non-observational studies. We have descriptive studies, which are studying the phenomena of interest, which is a phenomena of interest. Simple, you can have the CAP studies coming in observation, like the knowledge, attitude, practices. In our nursing profession, we have a lot of CAP studies. Then we have analytical studies. Again, I'm telling what is analytical. When you are trying to test a different kind of risk factors, contributory factors towards a disease condition. Then we have retrospective studies, which are going from present to the past. They are called as the retrospective studies, going from present to the past. Perspective goes from present to the future. What is ambispective? You want to see a study of past also and present also. That is ambispective study. Okay. And then the current studies. Now the study design options we have. One is the case report. Case report, like you see any case, a new case as a doctor or nurse to see in a hospital, you take the ethical permission of the patient, you blindfold the patient, and then you get it published into any research journal. That's the case report. So what are the new learning in the case report? In a case study or a case report, you are trying to compare the symptoms of the patient with the symptoms which are written in the book. And what is the new learning in that? What do you think that if you publish it in any research journal, what the readers will get a novel idea or something new, some new insights are coming out of the research. That's the case report. Then we have case series. Okay, similarly, on a certain number of different like some new disease has occurred in some different kind of same you can say kind of patients, we have the case series design. What is correlational study? Correlational, when there is, what is the meaning of the word correlated? Relationship you're trying to find out between the two different parameters. Correlational study. Okay. Then cross-sectional study. Then we have CAP study as cross-sectional is at one point of time. At one point of time, like in this month or in this days of a week. Cross-sectional study. It's a part of descriptive study. Okay. Then we have longitudinal studies. Opinion simple studies, we have the knowledge, we have the attitude and the practices. Mostly social science researchers, sociology, psychology, anthropology, medical anthropology, social anthropology, even in nursing profession, because we have very less info data collection, we are undergoing this kind of CAP study. Simple knowledge of students regarding breast cancer, knowledge regarding cervical cancer, attitude, what are the attitudes regarding nursing profession, what are the attitudes regarding, you can say, nosocomial infection, what are the practices? For example, I'm telling you, like I did a study on my bachelor, in my master's study, I did a quasi-experimental study on infection control. It's a kind of an experimental study. And in practices studies, we can have like, what are the practices of nurses? See, knowledge everyone has regarding infection control, but ultimately practices matter. If your practices are default, they're faulty, Even if you have the knowledge, it's of no value. We all have the knowledge regarding prevention of HAI or nosocomial infection in the hospitals. But when it comes to practicing, we all are highly erroneous, lackadaisical, careless. So this is my bachelor's BSc nursing study where I did this CAP study in which I studied the practices of the nurses towards infection control. None of them, they were removing their rings and their bangles from their hands before touching the patients. None of them were actually washing their hands with the 12 techniques by the WHO. None of them. None of them even bothered to wash their hands while giving medications to another patient. This was what I found in the practice, which were totally erroneous, erratic. Okay. Then comes the case control study. We have the cases and the controls. Okay. Then we have is the cohort study. What is the meaning of the word cohort? A group of similar people having a group of sample which has some certain same characteristics, like birthday cohort. My birthday is in the month of January. So we can have the birthday cohort of the same people. Like I did my MPH, we have the cohort of MPH 2020 batch. That is the cohort. Cohort means that there are characteristics, you can say, the characteristics are, some characteristics are matching in the research participants. Okay, so cohort of birthday cohort, class, same class students cohort, cohort of, like right now you are sitting here, whatever course you are doing here, this is going on, we can say a cohort of this students from Gorakhpur. Okay, cohort of Gorakhpur. So that's a cohort study. The study design types are qualitative. Qualitative studies are where you do not have to find a sample size. Sample size calculation is not required till you achieve a point of saturation. In this type of studies, we have phenomenological studies, ethnographical studies, grounded theories. Okay, we have this kind of research designs when it comes to qualitative research design. Case study is also a qualitative study. Case series. Okay. So these are where you are, so like you are trying to see the, now I'll give you an example of qualitative study. One of my friends did a study from CMC Vellore. She did a study on what are the painful perceptions or the perceptory, you can say, experiences of the people when they were actually, you can say, tsunami disaster took place, you can say, long back in the year 2004. Tsunami struck on 25th of this March, 24th night, Christmas night. It was a Christmas night. So what are the kind of painful experiences and what are the coping mechanisms of those fishermen who were in the Nangapatnam district of Tamil Nadu, where the biggest mortality, the biggest catastrophe of tsunami was there. So in one family, she had to go for at least 5 to 6 number of times. So after taking data from 30 patients, same results were there. So she achieved data saturation. So this is another form of phenomenological study, where we are studying the phenomena in quite detail. Okay. So this kind of studies, and we have the ethnographical studies. Okay. We have this kind of study designs when we come to qualitative. Then we have the quantitative research designs. Quantitative is obviously when you are taking a sample and then again sample size has to be calculated, hypothesis has to be made, everything has to be done. So these are quite detailed studies which require a lot of money, resources and material. So here this kind of studies are either experimental or they are observational. So in the, if we see the observational studies, we see here we are studying the rates of disease in a specific population group. They are used to describe the associations between exposure and disease. That is to measure the risk factors, measurement of risk factors. To study the risk factors each and every, we have analytical studies. Here we are actually measuring the risk factors and to describe the association. Okay, it can be either a case cohort study, a case control, a cross-sectional, ecological, a case series, or a case report. It can be quantitative or it can be qualitative. It is often used to generate rather test the hypothesis. Okay, so now Here, this is how we are doing. This is experimental study, and this is the researcher assigned exposures. Where there are no exposures, no a third exposure is there, that's the kind of observational study. Simply you're observing. Whatever method you have interview technique, you have with your own observation, empirical observation. And it when you are actually assigning exposures, yes, it is yes. Exposures means it's an experimental study. When you're giving exposure, it's going to be an experiment. When there is no exposure, then it has to be an observational study. And then observational study, is there a comparison group? Comparison, as I told you, then it has to be two forms. Either yes, if there is a comparison, then it has to be analytical study. If there is no comparison, then it has to be a descriptive study. And now if we come to the experimental, we have randomized controlled trials. Okay, if it is randomized, you are randomly selecting it. What is the meaning of the word randomization? Randomization means each and every participant has got equal chance of getting selected. Okay, each and every person has got the chance of getting selected. Okay, am I audible to everyone? Dharmendra, am I audible to everyone? Dharmendra, are you there?
Yes, ma'am.
Am I audible to everyone?
Yes.
Okay, and if the allocation is random, is allocation random, then it has to be a randomized controlled trial. Again, there is experimental group and there is a control group. Okay, but you are randomly taking each and every sample. Random means every research participant has got equal chance of getting selected. And if the random allocation is not there, then it's going to be a non-randomized trial. Now I again come to the analytical study. When we are going for observational study, now it comes to analytical when there is a control, when there is a comparison group. What is the direction? You're seeing the exposure to the outcome. Exposure means coronavirus has occurred or not. If it has occurred, see here clearly, exposure, you are trying to give virus and trying to see the outcome. Then it's going to be a cohort study on same group of people. That is exposure to the outcome, EO, exposure to the outcome. But where already outcome is there, corona is there, and you are trying to see the different kind of risk factor to find out the exposure, what made them to undergo corona or any disease, then it's going to be a case control study. And where you're studying at one point, you're studying seeing the study, exposure and outcome at the same time, then it's going to be a cross-sectional study. At one point of time, when you're collecting data, that's a cross-sectional study. Okay. Now we are studying the quantitative designs. So observation studies do not involve any kind of intervention or experiment. And in experimental studies, they entail manipulation of study factor. That is the exposure. You're trying to give us some new drug. Okay. Or you're trying to find out the efficacy of one drug on a patient. You're trying to compare the two different kind of drugs. Manipulation of the study factor. That we have three things: manipulation, control, and randomization. All experimental studies go by these three things. Cramp it in your mind. Put it into your mind in a very strong way. Manipulation, control, and randomization. And what is randomization? As I explained you, 2 times I've explained you earlier also. The subjects to treatment, randomization of these subjects to treatment or exposure groups. Observational designs. Here, the selected units are the individuals or the groups. The study population is either cross-sectional or longitudinal. Data collection timing is prospective. Prospective, which goes in the further. Retrospective goes in the back. Back, I'm saying back. Present to the past. Present to future is the prospective. And then is the ambivalence, that is called as the combination of both retrospective as well as the prospective. Data collection, again, I told you primary and secondary. Study population. Now see once again, I have told you already several times, cross-section where one set of observation is collected for every unit study at certain point of time, in one point of time, disregarding the length of time. 1 month or 1 week at one point of time. Longitudinal is there when we have 2 or more sets of observations, like in this month's end, then at the end of 2 months, at the end of 3 months, or 3 times in a year. Okay. In this, follow-up is also required. They're very difficult to conduct. They're very challenging because there are a lot of there is a lot of dropout factors coming here. longitudinal where 2 or more sets of observation are collected for every unit in the study. So it can be a cohort study over a specified period of time. So such populations are at risk disease-free at the start of this study. Most of the times it's disease-free. Okay. Disease-free means, again, it can be what I told you. What I told you. Exposure we are trying to find out here. We are trying to find out, see here, at the last part, what I told you. Exposure to outcome is the cohort study. Exposure already is exposure. We are giving kind of something exposure to somebody, and then we're seeing the outcome. And where is the opposite? That is from outcome is already there. You're trying to find out the exposure. Okay, that is the case control. So now the case series or the clinical, it's usually a coherent or consecutive set of cases of disease of similar, like we have 10 cases of tetralogy of Fallot. Like in the pediatric ICU of the PJ, we have a lot of children who are coming with tetralogy of Fallot. We have a lot of children who are coming with kidney diseases. Same group, the kidney disease has a lot of diseases in that. Okay. So now which derived from either the practice of one or more healthcare professional or a defined healthcare setting or practice. A case series is a register of the cases. Okay. Analyze cases together to learn about disease. Like in case study, we have the one case. Clinical case series has different kind of, you can say, a design, the same kind of disease in different kind of people. Where you are trying case series, there is coherent and consecutive set of cases of a disease which derived from either the practice of one or more healthcare professionals. We are analyzing the cases together, like 4 cases of heart attacks, 4 cases of anginas. So clinical case series are of value in epidemiology for studying the signs and symptoms, creating case definitions, and clinical education, audit, and research. Like if you see coronavirus, I have seen in multiple people in one family. Okay, but the deaths are in one family, we have 2 deaths for corona, but the whole family got affected by corona. Why so? And in one neighborhood, I see there are 10 young men who got corona, but only 5 of them had symptoms of corona. Rest were asymptomatic. So also there, we can have a case series. So case series, when we have population based, when a clinical case series is complete for a defined geographical area for which the population is known, that is called as population based case. As I said, in my neighborhood, we have so many families which were afflicted by corona, but very few of them they died, very few of them they went to the hospital. Epidemiologically, the most important case series are register of serious disease or deaths with the NCDs, non-communicable disease. As I told you, non-communicable diseases are like heart attacks, strokes, CVAs, okay, diabetes mellitus. They are the non-communicable diseases. They are usually combined for administrative purpose, or you can say for the legal reasons. So case series, what are the requirements for interpretation? We have the same thing, time, place, person, and to see the size and characteristics of the population at risk. Population at risk, by when we will find the results. Okay, when corona happened in this neighborhood, in this, you can say street, it actually happened, the corona. So what is the other people living in that neighborhood will also have the risk of corona. Like these 2 families are already afflicted. These men are already afflicted. These families are already afflicted. Okay. So case series, what additional data we have cases may also be contacted for additional information. This may turn a case series design into a cohort. Obviously, in the cohort of corona people in one colony. Now it's a cohort because I told you cohort is, so there is some similarity in either of their characteristics. Birthday cohort, neighborhood cohort, okay, disease cohort, same cohort. So case series can also be linked to other health. Here we can make a correlation also. Correlation means that we can find link to the other health data which is linked to the past or in the future. Mortality data can be linked to hospital admissions, including at birth and childhood or the cancer registration, etc. So case series strengths are, they point out a truly national and even international population perspective on a disease. When we undertake a case series design, we are able to give a nutshell of the kind of insights where we are painting a truly national. It's a kind of a, you can say, wake up call for our national administrators or for the local epidemiologists also. Secondly, disease patterns can be related to aspects of society or the environment. For example, ozone concentration at ground level and the thickness of ozone layer in the Earth's atmosphere. So here another correlation is also coming. When a correlation is also coming up, so you can say it's a kind of you can say case series. Here are the strengths. So here you can say onset of disease. Here they have died. Here you can say these are the what we are doing is on the onset or the condition of interest. How many have died with the time frame? With a time frame at the you can say at 1 week or 2 weeks or 3 weeks. This is just a kind of vague diagram which I'm trying to show here. How many have died at this kind of weeks and how many have died at one kind of time. Now comes the cross-sectional studies. In majority in my career in public health or as a community health nursing personnel, I've seen a lot of research is being conducted by the epidemiologists in the cross-sectional studies or the community studies. Most of them are the surveys, census surveys. Simply, you can say we are doing a survey. Here we are measuring all variables on participants at same point in time, same point in time. So measures the prevalence disease, not the incidence. Cross-sectional study, we are seeing at one point of time, so we are seeing the prevalence of the disease exposure, disease and the exposure over the time. Here you are seeing the prevalence. Prevalence again means old and the new cases. Incidence comes only with the new cases. Cross-sectional studies. So now we are defining the defined population, sampling, where there is an exposure or disease, collect data on this on outcome, disease and exposure or the risk factor, not exposed or disease, which are the exposed people, but they are not disease. Like in my neighborhood, when the corona was there in Patiala, we have a lot of people who were exposed, but they didn't get corona. Then there were people who were not exposed and they didn't get disease. There were some people who were exposed and they got disease. But wonders of wonders, there were some people who are not exposed, they were never exposed till they got corona. So there were a lot of speculations in the environment. So I think more than a pandemic, this disease has taken the form of an infodemic. So much traumatizing events I have witnessed when the corona was going on. A lot of people who were not exposed, they got corona. And some were even exposed, doctors and nurses, and they were not diseased. So this is how you will be going ahead with your sampling, keeping in view the defined population. Now comes the case control studies. As I told you, case control studies will be finding out the different factors of the disease. Agent, host, and the environment effect. Epidemiological triad is agent, host is me, the human being or the patient, and the environmental factors. Physical factors, climatic factors, geographical factors. We have the socio-cultural factors, socio-political factors. We have so many. So here the merits are they're least expensive, least time consuming. The characteristics are on two source populations, assumptions that non-cases are representative of the source population of cases, limitations not suitable for rare exposures, liable to selection bias. And here we are seeing the odds ratio. Odds ratio, we'll be finding in the further epidemiological. Cross here comes the odds ratio. We'll be finding out to find out, we'll be undertaking to interpret the results of the case control study in an epidemiological scenario in the society or the community. Sets of cases usually from health services, comparable sets of control from different sources. Both exposures groups are evaluated on characteristics or the exposures of interest. Compare distribution of exposures in cases and controls. Distribution of exposure. Distribution, how is the disease? Distribution disease coming up in a particular area. What is the distribution of disease, frequency of disease, and what are the risk factors? So you are comparing the distribution of exposure in cases and controls. Now comes cases which are exposed. This is how this study is going on, exposed and unexposed. Controls which were exposed and uncontrolled and unexposed. Example, does children's inhalation of hairspray facilitate development of asthma, bronchial asthma? When children inhale aerosols, or they inhale the hairsprays, there were 50 new cases of severe asthma identified in a primary health center in 12-month period, all less than 5 years of age. These cases were compared to 90 children less than 5 years attending PHC for orthopedic surgery, not for asthma, not for any other COPD condition, for orthopedic surgery. So they were not having the disease of asthma. So cases and controls are compared on maternal hairspray used since child's birth on the basis of the maternal hairspray. So now we are trying to find out the exposed population with the non-exposed groups. We have the cases and we have the controls. So controls have to be healthy children who do not have any COPD or chronic obstructive pulmonary disease. Asthma is one part of it. We have asthma, we have emphysema, we have atelectasis, we have bronchitis. There are 4 disease conditions coming in COPD. This COPD, bronchial asthma or bronchitis is part of COPD. So we are comparing it with healthy children, but the one who had orthopedic, like they had fractures or they have some sprains for which they are coming, but none of them, they had any asthmatic problem or any respiratory problem. They are the controls and these are the cases. Hairspray, children with asthma, and then we had no hairspray. Then we had children without asthma, they had hairspray and they had no hairspray. Okay. So case control studies, be particular. Now comes the biases. What is the meaning of the word bias? When this is, what is the meaning of the word bias? Who will tell me? Anybody from the group? You can put it in the chat. Anyone from the group? What is the meaning of the word bias? Anyone? Dharminder, are we allowed to question them? Are we allowed to question them? Dharminder, are you there?
Yes, ma'am. Actually, we will ask the question in the last of the session. In the meanwhile, they can write in the chat box.
Okay, I'm not able to see anyone. Now, there are 151 participants, only one chat I can see. Partial or skewed, not exactly partial or skewed. When there is we develop some kind of prejudice for something. Prejudice for something when we are actually, we are trying to see. Taking one side, biasism. Wrong finding found you to do something wrong. While sampling, yes, you are right. While sampling, yes, you are right. Okay. So without wasting your time, so we have the confounders. Groups are self-allocated, may have other risk factors with different distribution. Co-founders. Okay. Then we have this selection bias. Okay. Like control C. Now there are, in this case, I have seen mostly children in my clinical practice. I've seen mostly children from the urban areas. They are the one who are having asthmas because of a lot of pollutions, environmental, you can say contamination. I mean, there is there. Then we have, you can say atmospheric gases. We have different kind of pollutants, environmental, you can say these factors are there. If you see children you can say the village areas or rural, I have not seen, very rarely I've seen children in the rural area because they're in very much fresh air, they're amidst the nature's beauty, they're in the lush green fields, they have the fresh oxygen coming up. So I have not seen them getting asthmas. Okay. So I cannot compare children of urban asthmatic children with the rural asthmatic children. Somewhere some comparison has to be there. So selection bias should not be there. Then we have the recall bias. Sometimes I might be able to recall my past experiences. Sometimes I might not be able to. We ask about the exposure after the disease has been diagnosed. Okay. And then comes the interviewer bias. Sometimes it's best dealt by blindings. I will give an example of interviewer bias very nicely. When I had my study of BSc nursing, where I had to, you can say, do a research study, conduct a research study on a group of nurses working in the wards or in the clinical area, whether they were complying with the hospital infection, you can say protocols or not. What I did was, I did blinding. Blinding means that the person, there is single blind, we have double blind, and we have triple blind. I'll just tell you simply. In front of me, the nurses were, when I told them I'm going to undertake the study of infection control, they all, removed their rings, their bangles. They were trying to show that they are the best. Because I was standing in front of them to see their practice. But when I did a non-participatory observation, without letting them know that someone is observing them, okay, I didn't let them know, neither my team, my students. So that is non-participatory observation. Okay. Then the actual results came in front of us, because nurses became conscious by seeing that this madam is coming to evaluate us, our infection control compliance. Are we complying with the infection control protocols of the hospital or not? In front of me, they were the best ideologists. They were the real, you can say gentlemen cadets, no doubts. But when I took their non-participatory observation, then the actual results came in front of me. So this is best dealt by blinding. Sometimes interviewers are also biased when they try to make the results, already they have a pre-assumption of prejudice in their mind that the results will be like this only. Or they want to show the results or match the results with the kind of hypothesis they have. In those kind of situations, there is interviewer bias. So it is best dealt with blinding. Single blind when the participant doesn't know that he or she is being observed or interviewed. Double means that the interviewer, the research participant, as well as the investigator doesn't know that who is conducting the research study. And number third is a triple blind, where all three parties, neither the interviewer nor the participant nor somebody else, knows that the research is going on. This is dealt by pharmacological companies where triple blinds are there. In pharma, companies sponsor clinical trials. This kind of triple blinds I see. Otherwise, double blinding and single blinding, so we all are using in our daily lives also when we are undertaking any kind of research studies. Next comes the case control studies. Clear definition is cases and criteria used for inclusion. Now the controls here, they must come from the same population as the cases, and the selection should be independent of the exposure. Interviewers must be blinded to the case or control status of the subjects. Interviewers should use identical methods with cases. See, one case you are interviewing, second cases you are seeing the reports. That's wrong. If there is the method of data collection, has to be uniform. If one part you are taking on cases, you're doing the interview, on the controls, you cannot or ask somebody else to take the data, secondary source, or take the reports from someone, or ask someone else. Please make uniformity. Okay, it has to be uniformity has to be made. Okay. Investigators should carefully address confounding either in design stage or in error. Please mention it. If you think there is any kind of confounding variables are there, or there is any kind of biasism, please mention it. Please be truthful to whatever you do. It's better to be truthful than to be unethical. Never undertake any unethical study. Even though in books it is written that 0.5% manipulation can be done in the results, but not every time. It is there because sometimes the researcher really wants to, take out the results which are congruent with the hypothesis. Okay, but even if the results are opposite than your null hypothesis or with your hypothesis, it's better to show those results on. Okay, but never ever try to manipulate the study results. Next, this is the odds ratio, A by C and then by B by D. These are the cases, these are the exposures, these are the non-exposures. Odds ratio is A divided by C, and then again division by B, that is controls by the non-exposures. A are the cases, which are, this is the exposures, and these are the non-exposures. So A divided by C, again complete division by B divided by D. Now, what are the cohort studies? Dharmendra, I want one workshop where we can have some numerical, some you can say some exercises where we can teach them how to calculate the odds ratio in actual case control study. We'll have some you can say numerical studies, numerical questions in front of us, and then we can give they will all calculate the odds ratio using the numbers. Okay. We can give them some scenarios like cholera outbreak or TB outbreak, and we can have some numericals or some exercises. In that way, this concept will be much more clear than to just teach them in theory. This is my request. Are you listening, Dharmendra? Are you there?
Yes, ma'am, sure.
Yeah, fine, yeah. Now comes the cohort studies. In cohort studies, I told you, they are sometimes called as the prospective studies or the longitudinal studies, which are conducted over time. And here we are actually seeing the natural phenomena of it, natural history of disease. Or what happens next? What happens next to a group of the subjects? Subjects are enrolled at one point of time and then they are followed prospectively to measure their outcomes. In the future, they are studied. Okay. Here, the enrollment is usually specific. Case cohort studies are usually used to compare the health outcomes of groups of subjects in whom exposures or other attributes are different. Okay, they are the cohort studies. So the only type of study that can be used to accurately estimate incident rate, current rate of this disease. Okay, disease frequency or the incident rate. What is the current incident? To identify risk factors or to collect the information to describe the natural history or progress of disease. These type of studies are often expensive to conduct and slow to produce results because a large study sample and a long follow-up time are needed. Cohort studies are the most appropriate study design with which to establish temporal relationships. Temporal relationships. Okay, here comes the cohort studies. In this methods to minimize non-response, follow-up, and environmental bias essential for maintaining the scientific integrity. Scientific rigor has to be maintained. Scientific integrity has to be maintained. Exposure must be ascertained before the disease or outcome develops, and the disease must be classified without knowledge of exposure status. Exposure and then the outcome. Opposite to case control. Okay, where outcome and then we are seeing that cause of exposure. Okay, here it is exposure to outcome. There it is outcome to exposure. So now cohort characteristics, follow-up period, perspective, merits and no temporal ambiguity. Several outcomes could be studied at the same time. Limitations, they're expensive. They test your patience. They actually test your patience and time. Time consuming, inefficient for rare diseases, and may not be physical. And here you can find out the effect measure is by risk ratio or the relative risk. Relative risk. This is a design. See here, study population free of disease. Okay, factor present. Here there is no disease and the disease there. Where the factor is absent. If the factor is absent, then how come the patient got disease? I know many of my friends who got this disease, corona, even when they were not even exposed, they were living far away in the villages. How did they get corona? Is the disease there even if the factor is absent, or disease is not there? Present to future, and here the study begins, and we have to study with the design. Okay, we have the prospective cohort design, we have the retrospective design, and we have the ambiguity. So cohort design here, it starts with the group of individuals without the outcome of interest, exposure or at risk, follow forward in time to observe incidence of a disease, okay. It can be descriptive. Cohort studies can be descriptive or can be analytical. Cohort study can be descriptive or can be analytical. They are, don't confuse with the actual what I told you regarding descriptive study or analytical study. This is another subdivision of cohort study that is called as descriptive cohort study or descriptive or analytical cohort study. If analytical question, then measure the exposures on cohort at the beginning of the study. Okay. In analytical, if analytical question is there, then measure the exposures on cohort at the beginning of the study. It can be either descriptive or analytical, that is the cohort study. Cohort studies can be purely descriptive also. Okay, like what is the rate of remission among men treated for prostate cancer at GS, General Hospital, prostate cancer. So at-risk participants without outcome, who developed the outcome interest and who did not develop. Over time, I see. So at-risk participants, who are the people who are at risk of prostate cancer? Mostly old men, they have the prostate enlarged. What is the rate of, consider our example, rate of remission among men treated for prostate cancer. So obviously we have men with prostate cancer. Okay. So at-risk participants are there without outcome, but they are all having the prostate cancer. But how many of them, they, even after getting treated, how many of them they got remission of this? Remission means that again the cancer developed. Okay, so with time you'll see. So this is simply a descriptive study. or you can say the knowledge attitude practices. They're also like I want to see the knowledge of the students of 2020 group of 2020 batch of MBBS regarding Corona, because Corona had fared at that time. So it was simply descriptive cohort study, because I did this cohort study on a group of MBBS students of 2020 batch. Similarly, are here. This is a kindly purely descriptive where all patients of prostate cancer who got prostatectomy for removal of the prostate glands, okay, but how many of them again got remission over time, develop the outcome of interest, and who did not develop. This is simply descriptive cohort study. Now comes the analytical cohort study. See clearly here. We are seeing the different risk factors. Okay. In analytical example, do beta blockers increase the risk of renal transplant rejection? Do beta blockers increase the risk of renal transplant rejection? Beta blockers are given to control the hypertension of patients. Okay. If we are giving, because in kidney failure, because of the disruptive renin-angiotensin cycle in the body, patient's blood pressure and creatinine is always enhanced. In post-transplant patients, if you will be giving this, you want to see the risk of renal transplant rejection in the graph what they have taken. Okay. See here, study population without the outcome of interest. We are having that population which do not have any outcome of interest. Exposure is given and no exposure. Exposure did develop the interest, disease. Second is not developed. In when they were not who were not given beta blockers, did they develop the disease and who did not develop? Okay, one group is given beta blockers, second is not given. So here they develop. But again, there are a lot of ethical issues which will come. No doctor will allow their patients to undergo any kind of you can say challenging situation or any kind of disease, you can say risk population where there is any kind of risk to the, or when there is any kind of harm to the patient's physiology. So in this kind of study, a lot of ethical issues will come, and ethics committee will have to have, a strong discussion with the PI, with the physician who will be doing it, with the surgeon who will be doing it. So these kind of studies are kind of, you can say, analytical case control studies. This is a complete case of clinical analytical cohort study. Okay, so types of cohort I've explained you, prospective, and these are the types of studies. The prospective, and we have the retrospective. I explained you. Okay, so here the measure of association in a cohort study is seen by a relative risk factor. So in relative risk, we have A divided by A plus B. Again, complete division by C divided by C plus D. This is measure of association, the formula which is used when we are seeing to. Somebody has raised a hand. I can see here. Please, Dr. Ramesh, can you put your message? Let me see what question you have. Dr. Ramesh, there is some question by you. You can please text it. Or at the end of the chat, you can ask me. Dr. Ramesh, you can ask me. Dharminder, please please unmute this fellow, Dr. Ramesh Kayat. Dharminder, are you there? Kindly, could you please unmute Dr. Ramesh Kayat? He has a question here.
Ma'am, is it possible if you can explain about the beta blocker increase, how it increased? You were saying about that one, because I'm not a medical background. I'm from the computer background. But the topic, the beta blocker, can you tell me about that?
I'm saying beta blockers are used to control hypertension. Okay. Now, when beta blockers are being given to a patient of kidney transplantation, okay, already the patient is highly immunocompromised. Okay, lot of steroids are being given to patient. If beta blockers are
beta blocker also steroid, is it steroid?
No, dear, no. Beta blockers are to control hypertension of patients. They are given for controlling hypertension, increased blood pressure, my dear.
Yeah.
Increased blood pressure. Kidney patients, any kind of chronic kidney failure or acute failure will have increased hypertension because of disruption of the renin-angiotensin cycle in the body. In ARF or in CRF condition, ARF is acute renal failure, CRF is chronic renal failure. In CRF, or majority patients undergo, the kidney function is non-irreversible. In ARF, the kidney function is reversible, okay, by drugs and or by surgeries, okay. But in CRF, patient has to undergo long, very painful dialysis, and ultimately the solution is kidney, what I told you, transplant. So after transplant, patient is highly immunocompromised because somebody else's kidney is placed in his kidney. In layman language, if doctors continue giving him beta blockers, patient might go in hypertension, acute hypertension, hypotension, because they're going to reduce the BP. But in this kind of study, if you're undertaking, lot of ethical issues will
Is
come
there
up.
any another way other than the beta blocker we use? If we can reduce the
Calcium channel blockers
hypertension.
are there. We have calcium channel blockers. We have beta blockers for controlling hypertension. Yes, there is a complete list of pharmacological drugs.
Okay.
Classification is there, okay. But this kind of study, a lot of ethical issues will be there because the renal specialist will not allow his patients to undergo this experimentation.
Okay. Thank you.
Patient's relatives will not allow you.
Okay.
We can have any other example also. For example, the catheters which are used for putting inside the, you can say the cardiac catheters, what we are using to remove the blockades from the patient's, you can say cardiac arteries, that can also be seen. Which cardiac catheter, yeah, catheterization. So which number of catheter will be used, which quality of catheter will be used, which is the best quality of the what we call stunts in the cardiac stunting is there. Na? Cardiac stunts are there.
Yeah.
And the coronary artery bypass grafting is there. So which quality of stunt is the best, you can see for the patient. Lot of pharmacological studies are going on the heart patients. Dr. Britika Mitra, I think I've answered your question, but again, there will be a lot of ethical issues.
I got the. Okay, thank you. Thank you.
It's okay. Britika Mitra, please ask the question. Britika Mitra. Dharmendra, kindly unmute Britika Mitra. Where is she? Can I see her?
Hello.
Yes, madam. Please unmute.
Hello. I am Britika Mitra. Hello. Ma'am, I am audible?
Yes, you are.
Actually, I have a question regarding the, you told that the COVID, corona is a contagious disease. Still, when somebody is not exposed, still they are affected by the COVID. And there are so many people who are very much exposed, but they are not affected by the COVID-19. So how do you interpret this? How do you, why this is happening?
This is where analytical cohort study will take place, or you can take the form of a case control study. That why it is so. I have my friend who always goes to the hospital. He was a corona warrior who was working nicely, but he didn't get corona, whereas all the nurses and doctors who were working in the unit, they got. There are a lot of other factors. Maybe his immunity is much more. Maybe his ability to coping with disease is much more. Maybe he is already vaccinated. So, or to find out the different factors. Every human being, my dear, every individual has different immune factors. This you understand, na?
Yeah.
Host factors are different for everyone. So this is where the epidemiologist will play its part. Here you have to decide which design will you have to undertake. According to me, if I am there because the patient is not exposed, I'll go for a case control study, not a prospective cohort study.
Okay.
I'll go for a case control because exposure is not there. I'm still trying to see the outcome.
Okay, actually, this is very much surprising that maybe there
are thousands of cases are there, Dr. Whatever is your name, Dr. Britika. A lot of cases were there. I have seen a lot of administrators, even in WHO. Also, there were a lot of people who were we were there in the supplying kits to all the African countries and so many places where many of my people went in the field area. Many in the Gulf, they got this corona, and many didn't get corona. Here the epidemiologists will study why it is so. Are these because of these strong host factors? The ability to fight the disease, that the host factor is very strong, or are there something different?
Okay, but the people who are not actually exposed, so how they are affected?
This is what we have to study. This is what we have to study. And how did they got? Even there were so many village people who were there who got. There were so many villagers who were in the remote, far-flung areas. How did they get? Do you think it's something in the air only? Do you think there's something in the environment? Somewhere exposure has taken place, which we have to analyze. When we are not debating from topic, I have to answer everyone's question. Madam Priyanka, we have to answer everyone's question. They're also part of the group. So it doesn't matter. Let there be healthy discussion.
Okay, ma'am.
Yeah.
Okay, ma'am. Thank you.
Yes, Priyanka, Britika, there is a difference between randomized control trial and whatever you said. There is big difference. The line of demarcation is very, very light. See where there is exposure already has taken place or not. And where it has not taken place, then it has to be case control study. Okay. When exposure is there, it has to be which study? When exposure to outcome, which study? Cohort study. समझ आया कि नहीं आया?
Yeah, ma'am.
Exposure to outcome is the which study? Exposure to outcome.
Okay.
Exposure to outcome. And that is cohort study. Outcome to exposure is a case control study. Did you understand or not?
Yeah, ma'am. Thank you.
Okay. So here in cohort study, we have to find out the relative risk. This already we have explained. Remember, again, we'll have some numerical exercise on this. Okay. So principal difference between Dr. Shiva Jain, who's Shiva Jain? Can Shiva Jain?
Hello. Good evening, ma'am.
Yes, beta.
Yeah, ma'am, actually, I had a doubt regarding randomized control trials, like the experimental studies which we do. So I just had some doubts regarding the quasi-experimental and the experimental, like how to go about it.
My study was quasi-experimental for MSc. In quasi-experimental, one element is missing, either manipulation, control, or randomization. Okay. In randomized control trial, randomization will always be there. Okay. Randomized control group will always be there.
Okay.
But
so
there will not be any manipulation. But in quasi study, one element is missing out of the MCR.
Anyone could be missing.
And randomization. In my study, I did not go for any randomization. I selected I matched the cases and the controls. My case and control. I did matching. Matching has been done. See, there is a difference in your PhD. I'm non-PhD. There is a difference in your knowledge and my knowledge. Then how can comparison be made? Comparison should be made between the same people having the same variables, same demographic variables, same research variables. Samajh aayi?
Ma'am, like even if I'm, okay, ma'am, got it. Ma'am, like, so if I am doing a study in age-matched individuals, so it will not be a randomized study.
दोबारा बोलो, again.
Ma'am, age-matched अगर subjects लेती हूँ, if I take age-matched, and then I do a study, so I am not doing
not
it randomly.
Age, beta, not only age, many factors.
Yeah, other factors. Yeah, like just like BMI, age, occupation,
age, or gender, occupation, socio-economic status. हाँ ले ले, उसकी matching करोगे. बराबर 30 का ग्रुप बनेगा, बराबर 30 का इसका बनेगा. Then that will be a quasi-experimental study.
Okay, so I'm purposely
taking is the first prerequisite of a quasi study. लिख लो, बांधे बांध लो अपने बात. ये can't बांध लो अपने बात. Matching of the independent variables has to be there in quasi study.
Okay, okay, ma'am.
Then manipulation of the experimental group has to be done.
Experimental group manipulation and okay.
But nothing with the control group. And no randomization. एक मिस हो गया ना इसमें एलिमेंट MCR का, randomization is missing. मैनिपुलेट कर दिया और कंट्रोल ग्रुप को रखा आपने. ठीक है, ये होगी आपकी क्वेस्ट एक्सपेरिमेंट. In a randomized control trial, आपने completely randomized कर लिया, and then you see the exposure in the experiment. That's all.
Okay, all three are being followed. तब randomized होगा. अगर एक भी नहीं रहा तो it will go under quasi-experimental.
हाँ, quasi में आपने prerequisite है इसका.
Match करना.
Basic है इसका. That is matching of all the variables. हाँ, उसके लिए वो टेस्ट लगता है chi-square का. याद रखना. chi-square लगाना उसके लिए. मैचिंग करने के लिए. हाँ, chi-square लगना है इसमें हमारा मैचिंग के लिए. सारे इंडिपेंडेंट एज, सेक्स, एजुकेशन or and it has to come significant, chi-square.
Okay, ma'am. Okay, ma'am. Got it. Thank you so much, ma'am.
Most welcome. Now, somebody else is, I think, also raising a question here. There's someone. Anyways, you can ask me questions later on also, children. The principal differences are all the, all of them are teachers. I mean, I don't know the students where I'm teaching, are they the undergraduate or are they all professors? All of them are PhDs.
Ma'am, most of them are faculty and some research scholars are also there.
Oh, okay. I can see all of them are doctorates. So I'm saying them children. It's okay. Now, the principal difference between case control studies, cross-sectional studies, and cohort studies. Different population starts with affected subjects. In cross-sectional, all subjects are in. And cohort starts with healthy subjects. Jinka exposure ki nahi hua. Okay. I told you. Mayors incidence, no. Here there is no. Cohort there is no. Prevalence, no. That is no old and new cases. And then we have cross-sectional, we have yes. In cohort, we have no. Association, we have odds ratio. We have relative risk and the odds ratio both coming in cross-sectional studies. In case control, we have only the odds ratio. And then in the cohort, we have both relative risk, odds ratio, and the incidence rate ratio also. This you have to learn. Now, Dharmendra, do you think I should already more than 1 hour is going on, so we should be going with experiments? Shall I take another class?
Ma'am, can you give a brief like introduction, just what is experimental design? And after that, we will take the questions.
Yeah, sure. हाँ बच्चों, now in experimental group क्या होता है? Experiment जब आप करते हैं proper, in which a population is selected for a planned trial of a regimen whose effects are measured by comparing the outcome in the experimental versus the outcome in the control groups. Again, see here, such designs are differentiated from the observational design by the fact there is a manipulation of study. In observation, there is no manipulation, my dears. Here you have to manipulate. Like you're trying to give a test, a new intervention. अब टीचिंग टेक्निक देखो क्लासरूम की, क्लासरूम में टीचिंग आप लोग इंट्रोड्यूस कर दीजिए अपना, you introduce you can say this method what we call as a PowerPoint method, and one is just a chalkboard method. Okay, this introducing a new method. So in the experimental you are introducing a new method, that is a kind of manipulation. And then the randomization or the random allocation of subjects treatment or the exposure groups. So experiment where there is randomization, it will be called as randomized control trials. Where there is no randomization, that's a non-randomized control trial. This is the effect of treatment, like you are testing 2 different drugs on one patient, or one drug has to be tested on a patient. उस patient का जो group of patients उसके ऊपर आपने जब test करनी है वो दवाई, that will be the experimental. Either it can be randomized or it can be non-randomized. It's always better that you should go for, when you're going for an experimental study, you can go for a randomized control trial. You better randomize. Every research participant is, getting an opportunity. If you really want to particularly focus on a research, you want to truly test something or more authentic, much more results you require, or you want to actually see the null hypothesis, there you can go for a non-randomized. So this can also be case control and the cohort studies that are used to test the effect of an exposure when a randomized control trial cannot be used. Where it cannot be used, the randomized control trial, then you can go for a case control and a cohort study. Sometimes every study cannot be experimental. So again, you can go for a case control or a cohort study. Cohort analytical study भी कर सकते हैं. बहुत line of demarcation is very, very sharp, very thin. So be clear cut in your concept before choosing a study design. So here comes the experimental design, randomization. I told you outcome, no outcome, outcome and no outcome is the baseline and that's the future. Study begins here. When the randomization is there and when the randomization is not there. Types of trial, we have controlled and we have not controlled. Control, we have randomized, and randomized can be further blinded or non-blinded. And if it is a control, then it can also be non-randomized. Trial can be not controlled also. So randomized control trial, subjects are randomly allocated. Control can be given placebo. There are 2 groups of cancer patients. You are trying to test the pain medication in one patient. To the other group, what will you give? You'll give a placebo and see the effects. Placebo is a false drug, or you can say a drug which has no effect, simply placebo. That can be given. The results are obtained by comparison. Again, comparison has to be done. And this minimizes the selection bias and the confounding variables. So randomized control trial measurement bias can be reduced by double blinding, as I told you. Neither the investigator knows, nor the research participant knows that he or she is being undergoing an experiment. Okay. Randomized control trials can be used to test the efficacy, effectiveness, or equivalence of treatments and to test other healthcare practices and interventional strategies. So before subjects are enrolled in randomized control trials, the eligibility in terms of inclusion and exclusion criteria must be ascertained and informed consent must be taken whenever any new drug is to be tested. First of all, the patient ethical consent has to be taken. Doctor's consent. It has to pass through an institutional ethical committee. And if it is a drug of national importance, it has to undergo DCGI, Drug Controller General of India's guidelines. And ICMR also plays its part. DCGI, the ultimate drugs controlling body of the government of India. So it's more scientifically rigorous method with which we have to evaluate a new treatment. And this also, the sample size has to be calculated. Sample size formulas are there in the books on the internet. You can, there's another big class. I need to take a workshop for making you calculate the sample size. It cannot be taken like this. So randomized control trials, more rigorous scientific method. It has to have comparison group to eliminate the confounders, environmental exposures. Each subject has an equal chance of being allocated to a treatment or control group. Willingness to participate and other factors that may influence outcome do not influence the group allocation. So limitation is a need a very large sample size to measure the effects of infrequent adverse outcomes, and where there are strong treatment preferences, where patients really want to have a drug, there you cannot. There are a lot of biasness can also come. So again, we have to see what are the investigator biasism is coming here, or the confounding factors are there or not. They also cannot be compared where the groups are disappointed to receive the treatment. For example, I want to test a pain medication. I tell 20 patients, I'm giving you a medicine for pain control. When you're already telling them, patient will naturally have less pain. And when you are not telling them, then the results will come different. When you are telling them and giving them the drug, the results will come different. Here comes the research participant bias. So don't tell them. Okay. So they may exclude, and then the patients may not agree. Why are you giving my friend, the other patient in the bed, you are giving the placebo? And why you are giving me a pain-killing medicine? Why are you not giving the same medicine to them also? So here comes the investigator bias also. So very, very cleverly and very intelligently, you have to undertake a sample and explain the patient the procedure or the drug which has to be given beforehand in a very, very meticulous manner. And then again, a lot of patience is required. Patient dropout can also be there. That have to manage patient dropout. So benefits are, it eliminates the bias in treatment, produce unbiased comparison, provided you have good confounding bias and there is no up-selection bias. It facilitates blinding, masking of treatments from investigators, participants, and evaluators. Any difference in outcome between treatment groups is then not likely to be due to chance. No chance errors are here. So they are the gold standards, like trials of hormone replacement therapy in menopausal women found no protection for heart disease, contraindicating findings of the prior observational. This is also. Okay. So now I will, Madam Nilam Borade, definitely sampling workshop has to be taken where we'll have some different, you can say, sessions. And I really want to give you some numerical exercises regarding relative risk and odds ratio, which I will discuss with Dharminder in the due course of time. So in this, long time back, it was found out, I think in the late 80s, that if you start giving hormone replacement, medications to women undergoing menopause, they will give breast cancer to patients. But the latest research or the latest randomized control trials by the NIH of USA have found out there will be no There will be nothing is going to be, I mean, no mortality, no morbidity will be inflicted on the woman if you give them these drugs. They are the HRT, hormone replacement, after their now it is being proved. So this contraindicated the previous observational trials. They were the observational trials, but they were not the randomized control trials. But right now, lot of research studies are taking place. The biggest center for the WHO center for the biggest center of WHO of cancer is IARC in France. It's a place near Lyon. Right now, a lot of research studies are taking place over there to see the effects of fatty diet on breast cancer. So IARC France, International Agency for Research in Cancer, is the WHO Center for Cancer Control in the whole world, in the country France. It's a beautiful place called as Lyon, Lyon. They have a lot of training programs in your biostatistics also and cancer registry programs also. So they are now, right now, a lot of trials are undergoing over there. We cannot say the women who are daily eating chole bhature or, the Indian typical food, we have the paranthas and butters, they will have breast cancer. Why Americans are having? Why the red meat eaters are more prone to having cancers? Whereas now India is becoming, America is becoming the cancer hub of the world. Whereas Indians, if you see the parts of UP, you see the parts of South India, every day so many oily dosas, they are eating. You see parts of UP, with all due respect to the state of UP, my favorite state, I see them eating chola bhaturas and a lot of puri choles in the morning. Why are the women not getting the cancers there? Why the Kerala state in India is stopping in breast cancers? Whereas they're eating, Keralites are highly thin and they are thin and lean, and the BMIs are also highly, in control. Why so? There are a lot of other factors also. Right now, a lot of studies are taking place for the role of diet in cancers. Okay. So only randomized control trials or experimental studies will prove that, not observation. So randomized control trials or non-randomized control trials will give scientific rigor to your research. They are the gold standard. Never go for observation or descriptive studies. Advantages, again, this already we have covered. So disadvantage, large trials. Here the statistical power estimate may be difficult for you. Long-term follow-up, a lot of patients will drop out. They might not even cooperate with you. How many telephones you will be doing? Them. Compliance, they're expensive. And they have a public health perspective sometimes, yes. Yes, they have. And possible ethical question, as I told you. No patient will allow that, no doctor will allow the patient should be given, this kind of, drugs. I'm telling you, that's the reality. These are the non-randomized control trials. Here, you will not be randomly allocating the patients into experimental. Here, non-randomized means that you are here allocating the patients on the basis of their demographical factors. Is somebody asking a question? I'm getting distracted here. So here they are only used, these non-randomized clinical trial, where you are not satisfied with the results of randomized control trials. You're not satisfied. There you can go for non-randomized control trials. So selection bias is less likely to occur in trials. So non-randomized allocation naturally creates a greater potential for allocation bias to distort the results. Dr. MD Aziz Ahmed, do you have something to say? You can please So here generalizability of the outcome is also there. You can generalize the results. I cannot generalize the result. Generalize means that the results of your trial can be on larger population. You can imply on larger population. They are meaningful for a larger. I say in Patiala, if I do a study on 50 participants, I cannot say the results will be same for the entire India. No, the results cannot be generalized. They will not be meaningful. They will not give any insights. If the study sample is on 500 or 1000, then that results can be generalized. But this is not true in case of qualitative studies, only in terms of quantitative studies.